All right, we're going to cram as much as we can about thyroid into 11 and a half minutes. Red is for hyperthyroid, blue is for hypothyroid, and yellow are things that I think you'll be tested on. So first, let's talk about thyroiditis. This is simply inflammation of the thyroid, and it comprises 4 subcategories. The first is Hashimoto's. Typically, this is a non-tender goiter. Patients are hypothyroid. And on their labs, they'll have an elevated thyroid peroxidase. Treatment is, of course, thyroid replacement with Synthroid or levothyroxine. There are situations where you would not treat, and we'll talk about that. In these instances, if you have a diagnosis of Hashimoto's, they need labs monitored annually if they're subclinical hypothyroid, and that's because there's a risk of progression to fulminant hypothyroidism. The next type of thyroiditis we'll talk about is postpartum thyroiditis. This occurs within a year of some type of birth, miscarriage, or abortion. Typically, this begins as hyperthyroidism and is then followed by hypothyroidism after the thyroid tissue is destroyed. In some patients, this is transient and self-limiting. In others, the hypothyroidism phase becomes permanent. Treatment during the hyperthyroid phase is with beta blockers. And then, of course, during the hypo phase, we would use levothyroxine or Synthroid or thyroid replacement in most patients. And again, deciding to treat depends on what your symptoms and TSH are. If the patient has a TSH greater than 10, they would be treated for hypothyroidism postpartum. Or if their TSH is between 4 and 10, but they have symptoms. Or if this is a patient who desires fertility again, you would treat. I think this is highly testable, but the goal TSH for women with any type of hypothyroidism who are desiring fertility is less than 2.5. Let's quickly talk about silent thyroiditis. For all intents and purposes, it's the same as postpartum thyroiditis, but there was no pregnancy. And lastly, we're going to talk about subacute thyroiditis. Unlike the other 3 conditions, this usually presents with a painful thyroid. Patients are hyperthyroid. They'll have a low TSH, low radioactive uptake, and it's usually after a viral illness. This is a popular test question. Treatment for the painful thyroid is NSAIDs and aspirin, first line. Second line are steroids, particularly if the patient's in severe pain or they don't respond to NSAIDs and aspirin. We'll talk a little bit more about subacute thyroiditis in our workup for hyperthyroidism. But first, let's talk about subclinical hypothyroidism. I think this is also a highly testable area. Subclinical hypothyroidism is, of course, symptoms of hypothyroidism. Patients usually present with a high TSH, but then a normal free T4. Now, keep in mind, symptoms of hypothyroidism are easy to pick up on patients. These patients may or may not have symptoms. If they do, they'll be symptoms of hypothyroidism. Treatment is dependent upon what age group you're in. Those who are 65 and up, we should not treat even if they have symptoms. If they're less than 65, we should probably not treat, but there's limited evidence in this population. And there are, of course, exceptions. One we've talked about a couple times already, and that's pregnancy or women who desire fertility should be treated for subclinical hypothyroidism. Anyone with a TSH greater than 20 should be treated, and anyone with severe symptoms should be treated, regardless of their TSH range. To discuss hyperthyroidism, I'm just going to go through an algorithm for diagnostic and workup. So if you have a patient who presents with hyperthyroid symptoms, and remember we already talked about one of these, and that was subacute thyroiditis, the first thing you're going to do is get a TSH and reflex T4. If you happen to get a T3, I'll tell you what that shows. You're either going to see a low TSH or high TSH. If the TSH is low, it'll be associated with a high or normal T3, T4. The other outcome could, of course, be a high TSH, which will come along with a high T3, T4. In patients who have this situation, you're looking at a pituitary adenoma. Patients with a low TSH and higher normal T3, T4 should have a radioactive scan. If the uptake is low, you're dealing with thyroiditis, like we just talked about, subacute thyroiditis. Or this could be a patient who's taking thyroid medicine that they're not supposed to, so exogenous thyroid hormone. If the radioactive scan shows a high uptake, it'll have one of two patterns on the scan, and that's homogeneous. If you find homogeneous uptake on a radioactive scan, you're looking at Graves' disease. These patients will also have a positive thyrotropin receptor antibody. The alternative on a high radioactive scan is a nodular pattern. This can be further subdivided into a scan with multiple nodules, in which case you're looking at toxic multinodular goiter, or a single area of nodular uptake, in which case you're looking at a toxic adenoma. Treatment for hyperthyroidism is pretty simple. First line for most is methimazole. As usual, pregnant women are the exception. In the first trimester of pregnancy, propylthiouracil should be used instead. Your other options for treatment are radioactive ablation and, of course, thyroidectomy. Treatment depends upon symptoms. A couple things to consider. Radioactive ablation is the most common treatment for Graves'. And then any patient who has compressive symptoms, like like severe pain, dysphagia, voice change, they should be offered surgery. The Choosing Wisely campaign is basically specialists, governing bodies coming back to family physicians and giving us one or two tidbits that they would like us to follow. Choosing wisely in regard to thyroids, endocrinologists and radiologists have recommended we do not routinely order an ultrasound of a thyroid unless the patient has a palpable abnormality or they have those severe compressive symptoms or obstructive symptoms like severe pain, dysphagia, voice change, etc. The other Choosing Wisely recommendation is to not use or order T3, T4 when you're determining your levothyroxine dose. Now, obviously, T3 and T4 did have a role to play in our workup of some of these conditions, but it should not be used to guide treatment.